Good.
Okay, so welcome to our sixth webinar focused for the FRCS. And this time we have Dr. Farhan Syed, and he's a locum consultant from the University Hospital of Coventry. He has completed his FRCS and the EBOT as well. And he's going to talk about basic sciences, high-yield topics for the FRCS trauma and orthopedics. Thank you, Farhan, and now it's over to you.
Thank you, Dr. Hitesh. So with regards to basic sciences itself, as most of you who are going for exam are aware, this is a very important topic. You have one table viva on basic sciences. And unlike other clinical subjects where you can use your experience to answer it, basic sciences require a lot more preparation than that. And it's not a topic that you can miss. If you haven't read this topic or any topics related to basic sciences before, don't be surprised about the amount of information that you are getting. With practice, I'm sure you can master this topic and score highly in the exam. It's a very vast topic with regards to basic sciences itself. I will try to focus on a couple of topics which are high yield for your exam. Today, I'm going to focus on free body diagram for a hip joint and looking at the structure of the cartilage. When these topics come up in exam, you have something called as a starter question or a question that sets you up for your table viva. And that often is related to a clinical aspect. So with regards to cartilage, you can be shown an arthroscopic image or an MRI scan showing an osteochondral defect. And that's where your question starts with regards to asking the examiner, asking the candidate, what do you see? And then moving on to the structure of the cartilage. With regards to FRCS Orth, you also have to be prepared to draw diagrams. And to be honest, that's a good thing. I would struggle to explain a topic of basic sciences without drawing a diagram. It's much easier for you to draw the diagram, and examiners know that you have a good understanding of this topic. So with regards to preparation, again, for basic sciences, I would recommend a lot of practice. It's a topic that you have to discuss with your friends and colleagues regularly so that you can master it. And when you start speaking about it in exam, it will free flow. The flow will come out very smoothly. There is not one resource that you can rely on. I would recommend using multiple resources. Whatever suits your understanding, you can use that resource. But more than one resource will give you much more clarity of this topic. So starting with my first topic, which is free body diagram of the hip joint. It is probably one of the commonest questions that gets asked in the exam. And if you have practiced it, it's an easy, high scoring game. With regards to what is biomechanics, biomechanics is a study of the structure and the function of a living organism using principles of mechanics. So this is basically, you are translating your understanding of biology into physics. You are using the principles you have learned in physics with regards to forces, moment, arm, Newton's law, and using it to describe the movement that occurs in the body and the joints. Other three definitions that you have to be aware of is what is kinematics, kinetics, and kinesiology. And as you can read on the slide, kinematics refers to the study of motion without taking into consideration what exactly is causing this motion. And when you take into account the cause of the motion, the forces of the motion, then it's called as kinetics. And when you are studying human motions, it's referred to as kinesiology. If you start looking into various study material or resources, you will find that they start at a lot of basics with regards to looking at the laws of Newton, trigonometry, and it's good to have a foundation of those but before you start preparing yourself for the exam. So what's a free body diagram? Free body diagram is a graphical representation of the forces or the movements that are acting on a body that is in static equilibrium. What we mean by static equilibrium means that all the forces neutralize themselves so that the body is in equilibrium. The picture here shows you a pivot point and an arm and the force. the reason for putting this picture is to understand the concept of torque. Torque is a force which has a moment arm so that it produces rotatory movement. Using my cursor, I'm showing you the pivot for the force. If you imagine this as a door and pivot being a door hinge, and when you're trying to open a door, you would like to apply a force at the free edge of the door. That is, you're using the advantage of the long moment arm to open the door. Hence, the force you need to apply will be much less. Whereas if you want to open the door by pushing it near to the hinge, the force required will be a lot more. And if you understand this, you will be able to understand a lot more about how the forces act and what is the importance of the moment arm. Moving on to the next slide. The moment that you are asked to draw a free body diagram, you have to just spit out or mention this eight assumptions that we are making. The 8 assumptions are: bones are rigid rods, joints are frictionless hinges, there's no antagonistic muscle action. So you will see in your free body diagram that we are focusing on abductor forces. We have no mention of the adductor muscle or the adductor forces, which takes us back to this point that there is no antagonistic muscle action. We are not focusing on any internal forces. Our complete focus is on external forces and external moments. We make an assumption that all the weight of the body is concentrated in the center of the body mass. The line of action of the muscle is along the cross section. So if you imagine the cross section of the abductors, which is your gluteus medius and minimus, the center of it is the direction in which the muscle is acting. Muscle is assumed to apply tensile forces, whereas joint reaction forces are compressive. Again, this is something where there is no easy way out of it. You have to just by heart and be able to mention it whenever you are asked to put a free body diagram. We use a free body diagram to first find out what is an abductor force, second, what is a joint reaction force, and third, what are the factors that influence the joint reaction force. So we will spend some time on this slide looking at the free body diagram of the hip and breaking it down to the individual components so that we get our answers and we master this topic. In this diagram, using the cursor, there is a clockwise torque. The clockwise torque here is the body weight, and there is an anti-clockwise torque, which is the abductor force. And going back to our definition of free body diagram, the body is in static equilibrium. What we mean by that? The clockwise torque is equal to the anti-clockwise torque, and that's the mathematical equation here. And as we know, for a torque, there is a force and there is a moment arm. In this case, the clockwise torque is the body weight, and we have taken 5/6 of the body weight. The reason for taking 5/6 of the body weight is this is a single leg stance. So you subtract 1/6 of the body weight, which is the weight of your other limb. The moment arm here in this equation is 15 centimeter or 0.15 meters. And this is the distance from center of the femoral head to the center of the body weight. So this is your clockwise moment or the clockwise torque. Now going to the anti-clockwise moment or the anti-clockwise torque. This is the abductor force. Once again, some books have drawn this line in perpendicular direction. That's not correct, because we know from our assumptions or from our initial points, the line of action should be line of action of the abductor muscles. And we know that abductor muscles pass obliquely, and hence there is an oblique line of action. The distance is the perpendicular distance between the center of the femoral head and the line of action of the abductor force. Again, as you can see, the abductor muscles are much more nearer to the hip joint. Hence, this line is only 5 centimeters or 0.05 meters. Once we understand the clockwise and the anti-clockwise torque, we are able to calculate the abductor force. In this equation, if you know 3 out of the 4 values, you can calculate your abductor force. So we know body weight is 5/6 of the body weight. We know the moment arm is 15 centimeter. We know the moment arm for the abductor force is 5 centimeter. Using that equation, we have reached the answer 1,500 newtons. There are a couple of things I would like to clarify. With regards to body weight, we are converting body weight, which is in kgs, into newtons. For us to do that, we know that 1 kg of the body weight is 9.8 newtons. And taking 10 as a whole number, we have translated 60 kgs into 600 newtons. And that's where you get your 600 newtons from. And putting 5/6 is 500 newtons. So I hope it clarifies how we have reached to 1500 newtons. If you get this question in the exam, three out of the 4 values will be given to you, and that's when you have to calculate the force of the abductors. Once we have calculated the force of the abductors, we would like to know what's the joint reaction force, that is the force that is going through the hip joint. The joint reaction force is the summation of the force of the abductors and force of the body weight. And these are vectors. These are not scalar quantities. So you just can't add up 500 plus 1500 and say that it's 2000, because these are not scalar. By vector, it means it also has a direction. Books gives you 2 methods of calculating it. One is the trigonometric method. Second is the force triangle method. I would prefer using the force triangle method because it's simpler. And it's simpler for you to just draw it in exam and show the examiner that you know what you're talking about. So here, these lines are to the magnitude, in the sense that this line is short because it indicates 500 newtons, whereas this line is long, or 3 times this line, because it is 1500 newtons. And this line is drawn in the direction of your abductors. And the force triangle method states that once you join these 2 lines at an angle and draw a third line joining the free ends, you get the magnitude and the direction of your joint reaction force. So the pink line here indicates your joint reaction force. And if you use a scale to measure it, it will give you an answer. And trust me, it's not going to be 2000. Moving on to what happens, or what are the alterations in the hip biomechanics. What happens in hip osteoarthritis? In hip osteoarthritis, there is loss of friction in the joint. As there is degeneration in the cartilage becomes more rough. And as you know, once it becomes more rough, there is increased friction. This leads to increase in the joint reaction forces. So when you are trying to manage this problem conservatively, what you want to do is decrease the joint reaction force. The 3 common methods by which you can decrease the joint reaction force is: 1, by starting to use cane on the opposite side; number 2, by weight loss; number 3, by carrying a suitcase on the ipsilateral side. So once you have drawn a free body diagram of the hip, the next question that examiner will ask you is how well doing any of these 3 things alter the hip biomechanics. Once you know how to draw a free body diagram, it's very easy for you to add a stick or add a weight on the ipsilateral side to show how it affects. So as you can see, by adding a stick on the contralateral side, you are adding it to the contralateral torque, the anti-clockwise torque. So as we mentioned in our diagram, the clockwise torque is the body weight, the anti-clockwise torque is the abductor force. And as you can see, by adding the stick, it's aiding in your anti-clockwise torque. The stick generates a force of 100 newtons, and it has a very long moment arm of half meter or 0.5 meters. This aids in decreasing the abductor force, and once you decrease the abductor force, it decreases your joint reaction force. And here the conclusion being 15% body weight going through the stick leads to 60% decrease in the joint reaction force. And once there is decrease in the joint reaction force, it will help the patient in decreasing the pain it generates. This second diagram again shows a effect of adding weight on the ipsilateral side. So adding a weight or a suitcase on the ipsilateral side aids in the abductor force, which is one of the, as we mentioned, anti-clockwise force, and does help in reducing the joint reaction force. We don't advise our patients to carry suitcase because it's not practical. So the obvious practical advice is to advise them to carry cane on the opposite side. There are other ways with which you can reduce the joint reaction force. These include medializing the cup, where when you are doing your hip replacement, medializing the cup will increase the moment arm for your abductor force and help to decrease the force required in the abductors. Similarly, you can increase the moment arm by lateralizing your greater trochanter. The other two which we are aware of is by losing weight and Trendelenburg gait. What Trendelenburg gait does is shifts your center of mass laterally and increases the moment arm. And as we know, by increasing the moment arm, you decrease the force required from the body weight. So these three diagrams I'm going back to the slides, as these are the three important diagrams which you are likely to be asked in exam to draw. One is the free body diagram of the hip. Second is the effect of stick on the hip joint reaction forces of the hip. Third is the effect of carrying weight on the ipsilateral side. So having gone through this topic very, very fast, I will move on to the cartilage. Types of cartilage. The various types of cartilage that we come across in our body are the hyaline or the articular cartilage, the meniscus, which is a fibroelastic cartilage, the fibrocartilage, which is the tendon or the ligament insertion. So the tendon or the ligament, just before inserting in the muscle, converts into fibrocartilage. The elastic cartilage is found in the trachea, and finally, it's the physis and the growth plate. What is articular cartilage? Articular cartilage is made up of cells, which is chondrocytes, and extracellular matrix, which is formed by the water, collagen, and proteoglycan. Its main function is to decrease the friction and improve load distribution. So basically helping in the movement of the joint. As we know, it's avascular. The implication of it being avascular is it doesn't heal. Second, nutrition. The nutrition of the site is derived from the synovial fluid. Because it's avascular, there are no blood vessels that can carry nutrition to the cartilage. You have to rely on diffusion from the synovial fluid. Diffusion occurs when there is no loading. So when there is no loading of the joint, the diffusion of nutrients from the synovial fluid into the cartilage leads to nutrition. And when there is loading, it squeezes out the water, and this squeezing out brings out the waste products which enter the synovial fluid, and from there they get absorbed by the body. Hence, it's very important for us to maintain the movement of the joint in order to maintain the nutrition and the excretion function of the cartilage. Without motion, the waste products gets accumulated. Influx of nutrients doesn't occur, and that leads to degeneration in the cartilage. Now we are looking at the individual components that form the cartilage. We'll start with the chondrocyte. Chondrocyte is responsible for producing your extracellular matrix, that is the collagen and the proteoglycans. Unlike bone has a lot more cells. Bone has osteoblasts, osteoclasts, osteocytes. There's only one cell present in the cartilage, which is chondrocyte. These chondrocytes develop from the pluripotent mesenchymal cells, which forms chondroblasts. And these chondroblasts get trapped in the lacunae to form the chondrocytes. They respond to both mechanical and chemical stimuli, and hence you have your cartilage production. Hence, with loading, you get thicker cartilage. Immature cartilage cell has stem cells, whereas once the articular cartilage matures, it doesn't have any stem cells. So after discussing chondrocyte, we are moving about to the extracellular matrix. As we have seen in the previous slide, the extracellular matrix is made up of 3 components, which includes water, proteoglycans, and collagen. With regards to collagen, the main collagen which is present in the articular cartilage is type 2. In bone, we find type 1 collagen. In articular cartilage, we mainly find type 2 collagen. When we go into the layers of the cartilage, we'll find that at the base, there is calcified cartilage which attaches to the bone, and the type of collagen which is present in this calcified cartilage is type 10 collagen. How is this collagen synthesized? The chondrocytes produce polypeptide chains. These polypeptide chains enter the Golgi apparatus and gets converted to procollagen. This procollagen gets released into the extracellular matrix. The terminal ends of this procollagen uncoil to form the tropocollagen, and these tropocollagen attach to one another forming collagen fibrils, and these collagen fibrils forms bundles of collagen. Again, this is the diagram hasn't come out very well in this slide, but I'll try send you a better image of it. But what we have to understand is how this collagen is formed. Oh, sorry, moving on from collagen, this is diagram of proteoglycan. The image hasn't come out very well, but proteoglycan are mainly hydrophilic molecules. What it means is it attracts water, which is an important function of the cartilage. Once again, proteoglycan is produced by the chondrocytes. The most common proteoglycan is aggrecan. Aggrecan is made up of glycosaminoglycans. The 2 common glycosaminoglycans are the keratin sulfate and the chondroitin sulfate. In this diagram, you can see that there is keratin sulfate present at here, and the chondroitin sulfate which attaches to the protein core. This forms the polypeptide monomer. This polypeptide monomer attaches to the hyaluronic acid to form the proteoglycan. One common question that gets asked in the exam is what happens to the chondroitin and the keratin sulfate with aging. We know that the chondroitin sulfate decreases with aging, and the content of the keratin goes up with aging. After looking at the various components of the articular cartilage, let's look at the various layers which forms the articular cartilage. The various layers are the superficial or the gliding layer, the middle, which is the transitional zone, the third is the deep radial zone. Separating the radial zone from the calcified zone is the tide mark. Tide mark doesn't contain any cells or anything. It's just the most superficial layer of the calcified zone. And underlying the calcified zone or the calcified cartilage is your subchondral bone. The diagram here shows the various layers. We have to know what are the properties of each layer. So let's focus on the superficial zone first. What do we see in the superficial zone? The chondrocytes. The chondrocytes are flattened, and they are arranged as flattened in layers, and you can see the collagen fibers are arranged horizontally. So what's given here is that it's the thinnest zone. It has high collagen content, and as you can see, there is no proteoglycan. There are no red structures, and it's in immediate contact with the joint. And as we can see, the collagen fibers are parallel. The main function of the superficial gliding zone is to resist shear forces, and it has high tensile stiffness. And this high tensile stiffness comes from the collagen present in the superficial zone. Lamina splendens refers to the most superficial layer that protects the articular cartilage. You can imagine it as a polythene sheet which covers the articular cartilage and gives protection. It's a clear film and it's made up of flattened chondrocytes. It produces macrophages which has function of phagocytis. Staying with this diagram, you can see the second zone is the middle zone, and this is the largest zone. It forms almost 60 to 70% of the articular cartilage. It is in this area where mainly the proteoglycans are present, and progressively as you go to the deeper layers, the content of the GAG or the proteoglycans goes up. The collagen fibers in the middle zone are arranged obliquely, whereas once you go into the deep zone, they are arranged longitudinally. This slide gives you a very important concept of how the collagen fibers are arranged. As we know, this is a three-dimensional picture, but this picture is one-dimensional, and it shows the arcades of Beninghoff. So if these are the collagen fibers arranged in arcade, you can see that in the deep zone, they are vertical, and as you move into the middle zone, they become oblique, and they become horizontal or parallel to the surface once you go into the superficial zone. This is an important line diagram. When you are asked to draw a diagram of cartilage and the arrangement of collagen fibers, you can draw this diagram to explain the concept of arcades of Beninghoff. We have discussed the arcade of Beninghoff and the superficial zone. Once again, stressing on the importance of middle and the deep zone. Middle zone, as I have mentioned earlier, is the thickest zone with obliquely arranged fibers, and it forms the transition from shear forces. So we mentioned that the superficial zone has to face a lot of shear forces, and the deep zone has to face a lot of compressive forces. And this is the transitional zone. Sorry, this is the deep zone. Deep zone has the high proteoglycan content and a very low collagen content with a vertically arranged collagen fibers. Tide mark, as you know, is the calcified boundary between the deep and the calcified zone. Tide mark has no cells. It just refers to the most superficial layer of the calcified area. It migrates superficially with age. So as you know, with age, there's thinning of the cartilage, and as cartilage thins, the tide mark becomes more superficial. This is another important aspect you have to understand with regards to tide mark. If there is an injury to the cartilage and it doesn't disrupt the tide mark, then that cartilage doesn't heal. First, it's avascular, and there is no cells that can enter the cartilage for it to show this process of self-healing. That's why when you do an arthroscopic microfracture, what you do is drill holes and go beyond this tide mark into the bone, which generates cells that enter the cartilage and leads to formation of the fibrocartilage. Coming to the calcified zone or the calcified cartilage, this is the attachment of the cartilage to the subchondral bone. It forms a barrier to the blood vessels from the subchondral bone entering into the cartilage, which takes us back to the point of cartilage being avascular. There's virtually no type 2 collagen present in the calcified zone. The collagen present here is type 10 collagen. So if you go back to a few of my slides, there is a lot of repetition, and these are all high yield points that can come in your part 1 or the MCQs, being what is the type of collagen present in articular cartilage. Number 2 question being what is the type of collagen present in calcified zone. Number 3, what is tide mark? What is lamina splendens? All these are high yield points that will help you answer your MCQs. Biomechanical properties of the cartilage. Cartilage is viscous, elastic, just like like bone, which means it has viscosity and elasticity. And three important properties of being viscoelastic is: one, it has creep; second, it shows stress relaxation; and third, there is hysteresis. When we hopefully will get an opportunity to discuss these properties in future webinars, where we can go through each of these properties to understand them better. Second, it is anisotropic, which means the physical properties of the cartilage depends on the direction in which the forces are applied. So whether it's x-axis, y-axis, or the z-axis, cartilage behaves differently, and hence it is anisotropic. Second, it has third, it has low coefficient of friction, which is very important for the joint to move freely. It probably has one of the lowest coefficient of friction compared to most of the bearing surfaces available today. Fourth is the type of lubrication. The type of lubrication that you see in articular cartilage is elastohydrodynamic lubrication. What it means is, if you look at the image number 2, it shows deformation or elasticity. And when it gets deformed, there is hydrodynamic lubrication, where the fluid comes here and leads to allows the joint to glide or move together. Again, lubrication itself is a complete topic, which is a high yield topic that can get tested in exam. While we are discussing articular cartilage, commonly asked question is: what happens to articular cartilage with aging? What happens to articular cartilage with osteoarthritis? The things I have highlighted are previous questions asked in MCQ exam, and that is what happens to water. The water content with aging goes down, whereas with osteoarthritis, the water content actually goes up. And second is what happens to GAGs or the glycosaminoglycans. And as you can see, the keratin sulfate contents goes up with aging, whereas chondroitin sulfate content goes up with osteoarthritis. More than the content, it's about the ratio, and you have to remember, you have to answer or remember it as the ratio of keratin sulfate to the chondroitin sulfate. After discussing articular cartilage or the hyaline cartilage, let's move on to the fibroelastic cartilage, which is the meniscus. This is an actual station that came in my viva, where I was asked to draw a diagram of the meniscus. So there are two diagrams. One is this gross anatomy diagram, where you are showing your lateral and the medial meniscus and its relationship to ACL, PCL, and the collateral ligaments. Looking at the top. So again, this is, you can see that the medial meniscus is semicircular, whereas lateral meniscus is more circular. Lateral meniscus doesn't have any attachment to the lateral collateral ligament, which makes it more mobile, whereas the medial meniscus is attached to the medial meniscus, medial collateral ligament, which makes it less mobile and more prone to injuries. While drawing this diagram, you have to be careful about the relationship you have between the horns of the medial and lateral meniscus and the relationship of the cruciate ligaments to these horns. With regards to vascularity, at birth, the meniscus is completely vascularized. By the age of 10, only a central avascular area develops, and by the time you are an adult, only the peripheral 10 to 30% is vascular, or the red zone. This takes us into the concept of healing of a meniscal tear. As you know, the peripheral tears are better as they heal better because of better vascularity, and hence the meniscus is divided into the white zone, red white zone, and the red zone. The vascularity of the meniscus is derived mainly from the medial and the lateral geniculate arteries. These arteries form a perivascular plexus which send radial vessels, and as we know, that forms the 10 to 30% red zone. This is the second diagram, which shows the orientation of the collagen fibers within the meniscus. To start with, the meniscus itself is triangular in cross-section with thinner in the central part and the thicker peripheral. And it shows the perivascular capillary plexus, which is supplying the 10 to 30% of the meniscus. The collagen fibers are arranged circumferentially and radially. The circumferential fibers help to neutralize the hoop stresses and prevent tears from from propagating. This picture here shows the hoop stresses. What I mean by hoop stresses is a longitudinal force is converted into radial force, and this is known as the hoop stresses. And as I mentioned earlier, the circumferential fibers are important in maintaining these hoop stresses. With regards to functions of the meniscus, its main function is in load transmission. It acts as a shock absorber, and hence when there is meniscectomy done, it leads to increased contact pressures, leading to acceleration of osteoarthritic changes. Meniscus also helps with lubrication and joint stability. Now we have much better understanding how meniscus contributes to the stability. Hence, when you are doing a arthroscopic reconstruction of your ACL, it's important to conserve the medial meniscus per se by repairing the meniscus. And we know that especially the medial meniscus contributes to the anteroposterior stability. It's an important secondary stabilizer of the knee joint. With regards to proprioception, it has proprioception function, and this proprioception function comes from the nerve fibers, which are mainly innervating the anterior and posterior horns. So important high yield topics for your viva will be what is the structure of the meniscus. When asked to describe the structure of the meniscus, you have to draw the picture showing the medial and the lateral meniscus, and also the transaction of the meniscus. Second is developmental anomalies, again an important high yield topic, which is mainly focusing on discoid meniscus, types of discoid meniscus, and its treatment modalities. The picture here, the radiograph here, shows a plain radiograph AP of the knee of a discoid meniscus, and the X-ray changes you see in a discoid meniscus. These X-ray changes include the lateral tibial plateau being more concave, squaring of the lateral femoral condyle, and increased joint space, followed by the lateral tibial spine being hypoplastic. So these are the 4 changes that you see in presence of a discoid meniscus. Third basic sciences topic is with regards to types of tear. As you can see in the picture, there are various tears that can occur in a meniscus, which includes a vertical or a longitudinal tear, a radial tear or a flap tear, and a horizontal tear. And when this longitudinal tear propagates anterior to posterior, it can form a bucket handle tear. So your viva topic can start from showing you a picture of a meniscal tear progressing towards what is the blood supply of the meniscus, what are the various types of tears in the meniscus, how do you repair a meniscus. So as you can see, a basic science topic is mainly applied basic science, where you are using your knowledge of basic science in your clinical practice. With regards to meniscal healing, again, highlighting the significance of the blood supply to the meniscus and repairing the meniscus. From there, it can move towards repair versus resection. What is the current evidence and importance of repairing and conserving the meniscus? I will conclude my talk by this slide about growth plate. It's a very busy slide, but we'll try to focus on few points that can or will be asked in your exam. The picture on the left is a line diagram. So this is the diagram that you have to practice when you are asked to draw a picture of the physis, showing various zones of the physis, which includes the reserve zone, proliferative zone, and the hypertrophic zone. And we know that the hypertrophic zone is further divided into three parts, which is zone of maturation, zone of degeneration, and provisional calcification. And here you can see how there is difference in the arrangement and the number of the cells. In reserve zone, the cells are scanty, whereas and freely distributed, whereas as you move towards the bone or towards the diaphysis, you see that they are arranged in stacks. The commonly asked questions with regards to physis is what is the zone that is involved in storage disorders, and it's often the reserve zone that gets involved in lysosomal storage disorders. Also being asked about fractures. Fractures occur through the zone of provisional calcification, whereas disorders like achondroplasia and gigantism involve the proliferative zone. Again, this is the picture on your right is for your better understanding of structure of the physis. With regards to its vascularity, you have the nutrient vessels which enters the diaphysis, and it forms plexus just around the physis. Other important structure is the groove of Ranvier. The groove of Ranvier is present on the side of the physis, and it is responsible for the oppositional growth of the bone around the physis. Protecting the physis is the perichondrial fibrous ring of Lacrosse. All of these topics with regards to function of groove of Ranvier, perichondrial ring of the perichondrial fibrous ring, and these are all common, highly tested topics in the exam. Once, if we get an opportunity of discussing about physis, the physeal fractures, pediatric fractures, Sufi, we can discuss a bit more about the growth plate. I have put this slide just with regards to the cartilage and the structure and from basic sciences point of view. With regards to the references that I have used for preparation of this presentation, it's coming from these. You can go through those when you get a chance. Again, don't get intimidated by the amount of information that has come out from this presentation. As you go through this presentation and revise these topics, the number of times you go through, you will have much better grip, and you can easily answer these questions in your exam. I'm happy to take any questions.
Hi, Farhan.
Hi, Hitesh.
Yeah, thank you for that brilliant presentation. I mean, you've covered almost everything for the FRCS Viva. I mean, that's great.
Sure.
And let me see if there is someone waiting for questions. There are a few guys who are watching, but I don't know. They've not put up any questions in the chat box.
Yeah, I want to just stress on one important thing. First, can you hear me?
Yeah, we can hear you.
Yeah. Okay. One important thing about not getting intimidated by the amount of information in basic sciences. I still remember the first time reading it. Everything looks new. Everything is difficult to master. But as you practice it, you can master it. It's a very easy topic for good marks.
Okay. It's a sure shot answer because there is no controversy, right?
Yeah, exactly. And there is, with latest evidence, if you're looking at other adult pathology topics, you have to update yourself every time. Be aware of the latest joint registry data, see what's the recent evidence, recent paper. With basic sciences, there's none of that stuff. Once you master it and you can score it.
True. Cartilage structure is never going to change. It's going to be the same.
Exactly.
Okay. Let me see if there's any question. I mean, I'll just look forward. I mean,
sure.
There's no one who's right now there. I think some of them have already left because it's a long lecture. So no worries. We'll thank you, Farhan, for this great
Pleasure.
presentation. Taking time with
Pleasure.
us. I'm sure a lot of trainees all over the world are going to get benefited from your lecture.
I hope.
We can host more webinars very soon.
Sure. Yeah. I'll speak to you later. Thanks for the opportunity.
Thank you very much.